Next, that's why it is called a spastic. This hypertonia corresponds to spastic. You have a spastic hemiplegia. Is it clear? But in the case of extrapyramidal syndrome, it is instead a flaccid. In the case of lower motor neuron syndrome, it's going to be instead a flaccid paralysis, and not in pyramidal syndrome. So this one in pyramidal syndrome, you are going to have a spastic hemiplegia, which is going to move as a clasp knife movement. It's going to have a clasp knife movement, meaning that what when you try to relax the arm, it's going to come back very fast. Is it clear? Now, the fourth element after hypertonia, you are going to have hyperreflexia, and then the last element is going to be the hemianesthesia or hemihypoesthesia. So those are the different elements, and this is the most important element, the Babinski sign. When you have the Babinski sign it already shows that an upper motor neuron syndrome is already involved there. Is it clear? Then the other important element is going to be hemianesthesia, then you have hyporeflexia. So this is the order in which you should partake. You have pyramidal syndrome, and when you have a pyramidal syndrome, just know that the lesion generally is inside the central nervous system. Is it clear? Now, in contrary, we have what is called the lower motor neuron syndrome. The pyramidal syndrome is also called the upper motor neuron syndrome. We have what is the other contrary one is the lower motor neuron syndrome. This one is when you have an injury at the level of the peripheral nerves. When you have an injury at the level of the peripheral nerve, you're going to have a lower motor neuron syndrome. And the most important finding you must have there is going to be fasciculation. Is it clear? And fasciculation, what happened there? In fasciculation, when you slightly hit the muscle, the patient is going to have the muscle is going to have flickering movement, is going to contract by itself. Is it clear? You can see visible movement of the muscles when you can slightly pinch the muscle. That is fasciculation. The second element after fasciculation, you have hyporeflexia instead. You have the contrary in cases of pyramidal syndrome. You have hyporeflexia. You have a paralysis. Is it clear? Mostly at the level of a paralysis involved with the muscle that is going to be supplied by the peripheral nerve that is affected. Then after paralysis, it is going to be hypotonia. Is it clear? So since there is hypotonia and there is paralysis, the two is called a flaccid paralysis. Is it clear? So flaccid paralysis. Why in the case of a pyramidal syndrome, it was a spastic paralysis. Is it clear? And then the last element, you also have an anesthesia. Anesthesia provided that the peripheral nerve that is injured was also having a sensory function. So those are the different elements that you have to see when you say that in the history of a patient you have when you see a history of patient that has stroke, you have what? You have a focal neurology deficit of sudden onset. Is it clear? So those are the different focal neurology deficits that I've just shown to you. Now, the next element that you have to know is that the focal neurologic deficit, particularly the motor deficit, is it clear, can be proportionate. The focal neurologic deficit on your history, is it clear, in a history of stroke, the focal neurologic deficit can be proportionate or it can be disproportionate. Is it clear? Still on your history. Is it clear? So it can be proportionate or it can be disproportionate. Now, when the focal neurologic deficit is proportionate, what does it mean? So when you have a focal neurologic deficit which is proportionate, it means that in the upper and the lower limb, you have the same muscle power. The loss of power is the same in the upper and the lower limb. Is it clear? But when you have a disproportion, it means that you have lost power in the upper and lower limb, but one is more loss in power than the other one. Particularly, example, if you have an MRC classification of upper and lower limb to be 3/5, both of them, it means that it's a proportionate hemiplegia. But if you have an MRC classification of the lower limb to be 3/5 and the upper limb is 1/5, it means that it's a disproportionate hemiplegia. Is it clear? Now, how can this proportionate hemiplegia and disproportionate hemiplegia help you to give a diagnosis. So that is here that we are going to now visualize the homunculus. So let me just show you the diagram of homunculus for you to understand the reason why you need to evaluate if on your history if it is a proportionate or disproportionate hemiplegia. Now, on the history, you need to know that what zero. So for the homunculus, you need to know that the brain is going to look as such. So this is the brain as such here. This is how the brain resembles. So here you are going to have your internal capsule, which is at this level. You have another internal capsule which is this level. Is it clear? So let me just draw the diagram and then you visualize.